First of all, thanks to organs for this opportunity. I'm going to discuss regarding NTRK resistance and second line treatment, what we do offer. Dr. Bhavesh has discussed regarding the upfront NTRK mutated lung cancer, the first line management. Now I'm going to discuss regarding the sequencing, how we does. Next slide, please. So the TRK mediated downstreaming, if you see there are three pathways are there, like PA3K pathway as well as NTRK pathway and RAS-RAF pathway and everything. So there are three pathways put together will be activating the cancer which got TRK mutation positivity. So either like once mutation has happened, once this signal got affected, we do use the target therapy as Dr. Bhavesh mentioned, but there are some resisting mechanisms which can be acquired. It can be off target or it can be on target. Next slide. So the resistant to first generation TKI. So despite prolonged responses, many patients treated with first generation TKI inhibitors eventually will progress. If you see the larotrectinib, if you see the entrectinib, the PFS is limited. It's not just like ALK or EGFR, like where they do have a prolonged PFS. The PFS is limited. So why? What is the resistance to first generation TKIs? Next slide, please. The larotrectinib, entrectinib, the overall response rates, if you see, it is 81% and 58%. The duration of response, larotrectinib, it hasn't reached, and entrectinib 10.4 months. The PFS is 29.4 months versus 11.2 months. So compared to entrectinib, larotrectinib is having a better outcome in the PFS wise. Next slide. So though larotrectinib is an advanced version of in the first generation TKI, but still there are some mutations happening. Just like other TKIs, there can be mutations where the path can be crossed, or within the path also there can be some mutations can happen in the domains. So what are the mechanisms of resistance in TRK? On target as well as off target. If you see the on target here, within the three pathways like I mentioned before, in this there can be a mutation happen in the NTRK 1, 2, 3. So, and also the patient who progressed while being treated with the first generation TRK inhibitors reveal multiple mechanisms of resistance. On target kinase mutations can be addressed with the next generation TK, next generation NTRK inhibitors. Off target mutations, like we will discuss later. So, on target mutations we will discuss now. Off target, altogether, like a different mutations can happen, which can be tackled with the different receptors and the different TKs. The durability of response after elective therapy discontinuation under investigation. Next slide. So on-target resistance is a common after TRK inhibition. It alters a hydrophilic portion of the NTRK kinase mutation. So NTRK3, G2, 3R and the NTRK1, G5, 9R mutations are most common one to be seen. So there are solvent front, gatekeeper as well as DFIG. Out of this, the solvent front is the most common thing to be seen. Next slide. There are quite a bit of receptor variants are like they can be seen. So every variant like can be targeted if possible if it is on target. Next slide. The TRK resistance mechanisms, how we do test. The initial test like whatever was done by the Garden 360. So the samples obtained following progression on prior TRK inhibitors and before seltrectinib treatment were sequenced according to the availability. Plasma is by Garden 360, tissue locally as per institution standards. Patient classification got done. If only one sample plasma tissue with the TRK resistance, patient classified on basis of the positivity finding. If both sample the plasma and tissue partially conclude for TRK inhibition resistance finding in plasma, but only one in tissue, patients classified on basis of the in tissue. So between plasma and tissue, like we have to give like a tissue an importance. Next slide. How the treatment algorithm for TRK fusion positive cancers do happen. The first generation we introduce, if you are primary refractory to entrectinib, larotrectinib, we have to reconsider the testing because the chance of false positivity is also there. So post progression on first generation, it's not refractory. Post progression on first generation TKI, if it is oligo progression or solitary site progression, we always do consider local therapy and continuation of the same TKI just like other cancers or other type of lung cancer. If it is on target resistance, we have a second generation TRK inhibitors, that is repotrectinib and selitrectinib. If it is off target resistance, I mentioned before, if it is a KRAS, metamplification, BRAF mutation or like other, it can be targeted with other TKIs or other treatment if required. Next slide. So next-gen TRK TKIs can address on-target resistance to early generation TRK resistance. If you see here, NTRK fusion and NTRK mutation. So NTRK fusion can be easily addressed with a laratriptan and entrectinib, but if it's a mutation had happened, that can't be really tackled with the first generation TKI. We have to introduce a second generation TKI. Here the tumor is heterogeneous. So these second generation TKIs can handle both fusion as well as mutation very well. So repotrectinib as well as selitrectinib, we'll discuss a bit data. If you see the selitrectinib, it is a selective TRK inhibitor. If you see the repotrectinib, it is not just TRK, it's also RAS and ALK inhibitor, which is multi-kinase, I would say. Next slide. So second generation TRK inhibitors designed to overcome on-target resistance. If you see here, the domains and everything, there is a ATP, two ATPs like binding, everything like got easily amalgamated with this. Next slide. So this is the data of selitrectinib on a second generation selective TRK inhibitions in NTRK fusion positive solid malignancies. Here, it's a phase 1, phase 2. If you see the dose adjusted, the phase 1 is a dose escalation and phase 2 is dose expansion study. So all the tumors which got included are their progress on the first generation TKIs, that's NTRK inhibitors. The primary objective here is a RP2D in patients aged less than 12 as well as more than 2. Less than 12, 43 mg per meter square, more than 12, 100 mg per meter square they did, that the BD dose. And the phase 2 dose expansion they did again. Next slide. In this, if you see the analysis of the data from phase 1 study, the compassionate use experience, so it's 32 mg QD to 150 mg BD is there, the two arms, the less than 12 years and more than 12 years. If you see here, the solvent trend is a significant number, next is a gatekeeper and the kinase mutation domain. And there is a plethora of range is there. So in this one, the use of experience in this, the outcomes are good. The solvent trend mutations have a very good response with the selitrectinib. Next slide. So it can address NGS can address on-target resistance to early gen TKIs really well. So that's what the prior study, this is the one data. If you see the solvent trend is the most common one, which can be tackled with selitrectinib really well. Next slide. So in this one, if you see what are the safety profile of the selitrectinib. So the ataxia dizziness is there, ataxia vomiting is there, rest are all, they are not dose limiting toxicities. So these are very minimal toxicities got noted in the phase 1 study. Next slide. The ataxia and dizziness is a predominant complaint where patient discontinued in the phase 1 study what we discussed before in the selitrectinib. Apart from that, no other dose limiting toxicities are really significant. Coming to the repotrectinib, the Trident 1 trial, a second generation TRK ROS inhibitor in ALK ROS NTRK positive solid tumors. Here, it's a phase 2 study and a phase 2 analysis of the international open label dose escalation expansion phase 1, phase 2 trial. This is having a slightly robust data and we know it's a multi-kinase inhibitor. I would add towards the repotrectinib because it's a multi-kinase inhibitor. So if you see here, the phase 2 primary endpoint is overall response rate. The phase 2 secondary endpoint is plasma concentration at RP2D and the duration of response and PFS, OS, interconnected overall response rates. Next slide. Repotrectinib in TRK TKI naive NTRK fusion positive solid tumor cohort from Trident 1 efficacy. If you see, the overall response rates are very good for nearly 40%. It's a second line and the duration of response is also very good. So it's almost nearly 7.4 months plus. Next slide. So repotrectinib in TRK TKI treated NTRK fusion positive solid, the response rates are very good. Among the patients who are seen, among 13 patients with NTRK solvent front resistance mechanism mutation, confirmed overall response rate of 54%. As I mentioned before, solvent front resistance mutations do have a good response compared to other mutations in the NTRK mutations profile. So if you see the solvent front resistance mutation patients having a very good response up to 54%. Next slide. What is the safety profile? We saw there is ataxia and dizziness is a significant safety profile for the selitrectinib. For this, grade 5 dyspnea occurred in one patient. The most treatment-related adverse events were low grade. So those are all nothing significant here. The dizziness was the most frequent one. With the most case, it's only being grade 1. Whereas in selitrectinib, the dizziness and ataxia were the dose-limiting toxicities with a significant grade. Here, it is it's only just grade 1. Patient is tolerating well. there is no discontinuation due to dizziness or ataxia, just like other contemporary contrary one, the selitrectinib, there is a discontinuation due to the dizziness and ataxia. So treatment emergent adverse events at dose modifications, dose reduction happened in 27%, discontinuation is only 11%. Next slide.
I'm sorry to interrupt. Please conclude
And
your text in
yes,
next
yes.
1 minute.
Yeah, go to the final profile. This is the repetitive activity post resistance of entrectinib. Next slide. So off target or bypass path resistance can occur with the TRK inhibitor therapy. So off target we have to deal independently. Next slide. Next slide, please. Go to the, yeah. So these are the key points. How we manage acquired resistance with second generation TRK inhibitors. It's not just first generation. So multiple mechanisms of resistance are observed in patients treated with first generation TRK inhibitors. Genetic testing of biopsy at progression are ctDNA critical to understand mechanisms and options for further therapy. For those with on-target resistance, investigation of next generation TRK inhibitors are a promising option. For those with off-target resistance, consider standoff care and clinical trial options. Tumor flare can occur when stopping TRK inhibitors. Consider combination therapy always. With this, I conclude my session and thank organizers for this opportunity once again.